We are going to start. It's 12 o'clock as scheduled. We are going to start, and we once more want to welcome everybody for joining this webinar this morning. We appreciate your presence. We are delighted to have participants attend this portal webinar today. This webinar is actually the second in the series of webinars. The first was held on the 14th of July. So we hope more webinars will follow after today's webinar. So once more, we are glad to welcome you all, and we can assure you that it's going to be an interesting section. We have many participants from many countries attending this webinar today. And so, yeah, you're all welcome. Once more, I'm Dr. Sonny Ibeneme. I'm the Digital Health Specialist from the UNICEF IPRO region. So before we start, by way of housekeeping, we will start with a few announcements. So please remember to turn off your videos, mute your mic if you're not talking. And also remember that the Q&A features have been enabled for you to iteratively type in your questions and receive some answers. But yeah, we'll do a Q&A section at the end of the entire presentation, where some target questions will be posed to key presenters. And at the moment, today we have 4 presenters who will be giving in-depth presentation on topical topics related to this webinar. Without wasting more time, we'll be starting off this section today with open speech by Dr. Devi, who is our Chief Health Specialist. So Devi, please, can you take the floor, please?
Thank you so much, Sonny. I'm sorry, I can't switch on my video because it doesn't seem to be functioning. So I'll just go ahead with the audio, if that's okay. I just wanted to give a warm welcome to everyone for giving your time to this important webinar, especially in light of the COVID vaccine rollout and really rolling out to the population that immunization hasn't really reached before. And big thank you to the health team and the T4D team at UNICEF IPRO, as well as at UNICEF headquarters for organizing this. Very timely indeed. As you all know, there is going to be a lot more COVID vaccines available for countries in the remaining quarter of 2021, as well as in 2022. And with the rollout that's already happened, we're already seeing some challenges in some countries in reaching the susceptible population, particularly those most at risk, including the marginalized and hard to reach. So this webinar, this GIS-based digital microplanning, is going to be important in helping to reach those unreached and the vulnerable risk populations. And I believe this webinar is going to also inform you about the funding opportunities for this, as well as the technical assistance available that you can avail yourselves to in making and operationalizing this in your countries. Some of you are already familiar with this from measles and polio campaigns, but not all. And it's also going to be important in looking beyond the COVID-19 vaccine, because this is going to looking at the reaching those the underserved and marginalized. So really looking beyond to see what other routine immunization services, as well as other essential health services, and even outside of the health services can be looked at by using this technology. So yes, without further ado, thanks again for joining this, and hope you'll find this useful and are able to adapt it for the users beyond the COVID-19 vaccine as well. Thank you very much, and over back to Sonny.
Thank you so much, Dr. Devi, for that excellent opening remarks. And colleagues, as you can see, we are excited that we all joined us, and we are going to give you an interesting section this morning. So the next, please kindly check on the chat box. I've actually posted the video of DICE so that you can explore some of the conversations around the UNICEF DICE. So next, we are going to call on the first presenter, who actually go further deeper to give us some of these excellent presentations. I'm going to call on Dr. Karen Calandra. For your information, Dr. Calandra is our unit lead for digital health and information systems at UNICEF. Dr. Calandra is a senior health advisor and chief of the digital health and information unit in the UNICEF health section. She is the global lead for digital health and is responsible for coordination, planning, technical support, and evaluation of data and digital health initiatives for health system strengthening here at UNICEF. This includes operationalizing the UNICEF digital health approach and supporting the identification, validation, and scale-up of priority innovations of child health. She is also the lead of Digital Health Center of Excellence together with the WHO partners. She has previously worked as a senior research advisor at Malaria Consortium in the London, United Kingdom, and a visiting lecturer in the Department of Epidemiology and Biostatistics at University in Uganda. She's a specialist in pneumonia, digital health, and health systems research, as well as a community-based practice, primary healthcare. Dr. Calandra, please, the floor is yours.
Thank you, Sunny, and good morning, everyone from a rainy Sweden. Can you go to the next slide, please? I think the next one. There. Yes, great. So I'm going to just give a very quick overview of the topic we're on how we came to the topic that we're talking about today. So if you go to the next slide. So back when in October last year, almost a year ago, when we started meeting regularly with the WHO colleagues who worked on COVAX to discuss the key challenges that we knew were coming with the COVID vaccine rollout. And we all agreed that we thought, given the kind of stress that health systems is under in many countries in the world due to the COVID pandemic, we knew that there were a lot of opportunities that we could harness by scaling sustainable deployment of carefully chosen digital solutions that could address some of the health priorities related to both the COVID pandemic itself, but also to equitable vaccine rollout. Next slide. So we met regularly on a weekly basis with between Global Fund, Gavi, WHO, and UNICEF to really work out the key solutions that we thought could be useful around some of the main challenges and problem areas around COVID rollout. And this spanned across approaches for health worker training on a remotely, to have digital solutions for RTM, real-time monitoring for campaign planning, safety monitoring of the vaccine, routine monitoring of vaccination coverage, digital certificates, counterfeit detection, looking at traceability of the vaccine, and then finally around digital solutions and GIS solutions for microplanning. So across all these areas, we have now developed sort of standardized approaches, standardized indicators, and ways to support countries to deploy the solutions. But what was missing was this the coordinated technical assistance to countries to help now adapt and adopt some of these standardized approaches that we had worked around. Next slide. And this is when the idea of having a digital health center of excellence came up. And we floated this around with donor agencies, and very quickly we established what we now call the Digital Health Center of Excellence, which is a multi-agency consortium, which is led by UNICEF and WHO, and where UNICEF is running the day-to-day activities. It's meant to provide country offices with coordinated and standardized technical assistance, initially responding to requests that are around preparation and deployment of mature digital technologies that can not only support the COVID vaccine rollout, but also more broad health system strengthening and post-pandemic response plans. We also align regularly with donor agencies and support governments to identify funding opportunities for some of the costed investment cases that will come out of DICE. Next slide. I'm not going to go into too much detail on this, but basically what we're trying to do with this mechanism is to make sure that we respond to specific country demands, ideally with requests that come and are already incorporated in the National Deployment and Vaccination Plans, the NDVPs, or in other costed funding proposals that governments have endorsed. We want to make sure we are agile so that we establish mechanism to quickly can contract vendors or technical experts for countries. We want to make sure that the solutions we recommend are sustainable so that they can be owned by the governments and maintained beyond COVID and beyond COVID specific systems so that they have functionalities that benefit the broader health system. They need to be secure and safeguard the patient privacy and data protection regulations. And we also want to make sure we build capacity at country level as we move along. Next slide. Just a quick one on who supports DICE at the moment. So as you can see, we have UNICEF and WHO at the center of the operations. And then we have immediate participating organizations that fund this initiative, which includes Bill and Melinda Gates Foundation, Gavi, GIZ, and the USAID, who channel funding through Digital Square. But we also have a number of other donors who we report to and who feed back into DICE. Next slide. And some of the areas that DICE can support are around coordination between donors and development partners at regional and country level. We can also hire the technical assistance needed for countries to prepare concept notes, to conduct business requirements and look at the functional and non-functional requirements that are needed for a digital solution to be fitting within the health system. We can provide support to implementation of assessment tools of assessing the digital readiness of this, or the readiness of the health information system and things like that. So it's including sort of all the work that goes in before the actual deployment takes place. Next slide. So should you be interested at country level, you can send an email. We have an email address that I've put on this slide. Requests can come from anyone as long as the topic is endorsed and prioritized by the government, and that it has gone through existing country level technical and donor coordinating mechanisms, so that it's something that is agreed at country level to be something that should be invested in. We are not bypassing existing structures, so we're quite keen to make sure that also the coordination, the technical assistance that is fed back is also going via these groups that already work at country and regional levels. We want these TA ideally to be aligned with the national deployment and vaccination plans. And we are working very closely with the Gavi and Global Fund to make sure that any technical assistance requests that come to them is also flagged to DICE so that we can work on this together. Next slide. That's all I had. So with that, I hand over to you, Sunny. Thank you.
Okay, thank you so much, Dr. Karin, for that excellent presentation. And we will be summarizing that, coming back to you after now, to answer some questions that participants could have. So participants, I know you're curious, have some, want to get some more insight and feedback into what, that Karin had presented. So we'll come back to the Q&A section so that she could answer some questions that you may have. But now, and next we are going to, welcome on board Dr. Rocco on stage. So for information, Dr. Rocco is our health specialist, a GIS specialist here at UNICEF. Dr. Rocco is a lead of geospatial health at the UNICEF Health Section, New York. He is the focal point of the Gavi-funded UNICEF activities in GIS for immunization, and the UNICEF representative on the WHO-UNICEF GIS Working Group for COVID. Beyond global strategic partnership and coordination, Dr. Rocco has led for many UNICEF projects on the application of geospatial data and technologies for immunization and other related health programs threatening in countries, pretty much those in Myanmar, Mozambique, Ethiopia, Madagascar, Haiti, and Kenya. And he has also led the production of several guidance and documents related to the integration of geospatial data and technologies into countries' health information systems. So, Dr. Rocco, please, the floor is yours.
Thank you, Sunny, for the great presentation. Thank you, Karen, for starting us out. I would like in this next section to narrow the attention on one of the areas of priorities of the innovation group, and specifically the use of geospatial data and technology for immunization microplanning. Next slide, please. As anticipated by Karen, this is one of the areas that were identified as crucial to achieve equitable distribution of COVID-19 vaccines, and where the implementation of digital innovation was seen as a priority by the COVAX innovation groups. Next slide, please. So there's a number of key activities listed under the various pillars of the WHO COVID-19 strategic preparedness and response plan that directly linked to immunization microplanning. For example, it supports the mapping of vulnerable and hard to reach populations. It contributes to enhancing health facility readiness plans to ensure adequate resources are available. It directly supports the identification and implementation of vaccine delivery strategies to best reach specific target groups, and specifically aims at strengthening outreach activities that will be crucial to reach certain high-risk target groups. Next slide, please. So when we talk about digital microplans, as you probably well know, microplanning is a set of decision-making steps and tools to ensure that immunization services reach every community. Is used to analyze and use data at the district and health facility level to identify priority communities, address barriers to access and utilization of vaccination services. GIS, when we talk about GIS-based microplanning, we refer to the use of geospatial data technologies to characterize the geographic layout of health facility catchment areas and to provide value-added information from the geographic information systems that can support the various steps of the microplanning process. There is also a wide ecosystem of digital tools that can be associated to the various steps and support the various steps of the microplanning cycle. And some of these digital tools can also be linked to the geographic dimension that is established by GIS-based microplans. For example, the use of geographic information in the DHIS2 can support the reporting of microplanning information to higher levels. So this extends a little bit the benefit of building the GIS-based digital microplans to other to the wider digital microplanning environment. Next slide. Now, amongst the many challenges that have pointed to the prioritization of digital microplanning includes the new population targets with respect to what generally handled by routine vaccination strategies, which coupled to the frequently out of date or inexistent information on the distribution of target population within health facility catchment areas, and the fact that microplanning is generally done using paper-based system based on approximate geographic layout of health facilities catchment areas can lead to a number of potential risks for COVID-19 vaccine deployments. For example, missed settlement or communities, especially in remote areas, population not accounted for, and gaps and overlap in vaccine service areas that can lead to inefficient use of resources. And in addition, the use of approximate geographic microplan information can lead to poor transparency and accountability of microplans. Next slide, please. So the motivation behind the increasing interest in investments directed towards GIS-based digital microplanning is based on a number of factors. First, the increasing availability of high-resolution satellite imagery and derivative products such as location of building footprints, location of population settlements, and population estimates that can be derived by this new data products, is allowing better insight into the distribution of target population in a manner at times independent from census data. Second, the increasing integration of global positioning systems into user-friendly mobile application is increasing the availability at the grassroots level and at the community level to collect geolocated data and improve the geographic information that is available also at health facilities and district level. And third, the experience in learning the deployment of these technologies for polio and malaria microplanning has demonstrated benefit to the coverage, the reach, and accountability of vaccination activities. So all these factors provide opportunity to move from paper-based microplanning to more data-driven and digitally enabled microplans to support COVID-19 vaccine deployment. Next slide, please. So the use of these technologies can allow the realization of a number of core functionality. It is based on the utilization of spatial information on population distributions, together with the location of health infrastructures and information on the connecting environments, such as transportation networks or geographic barrier, to achieve a number of things. Demarcate accurate catchment areas of health facilities based on actual population movements, opportunities, locate target population within the health facilities catchment areas, assess the coverage of population by existing vaccination sites, and eventually identify areas that will require to be reached through other strategies such as mobile or outreach to ensure access by all populations. And finally, support the planning and logistics for mobile and outreach activities so that the efficient use of human resources and vaccine resources is done in a manner that is cognizant to the accessibility of communities. Next slide, please. This is quickly just the technical setup. Involves the use of a number of geospatial layers that can either be globally sourced or for example, like satellite imagery, or that are maintained at the country level, such as location of health facilities, and expose this information through dashboards or through printed GIS maps with some value-added information, for example, travel time to nearest health facilities, to communities that can support directly the microplanning decision-making process. And depending on the context, this can be done through dashboards, or it can be done through just printing microplan maps, as we've not done in a number of countries. Next slide, please. So some of the potential benefits of GIS-based digital microplan that can bring to COVID-19 vaccine rollout are clearly linked to the efficiency of the microplanning process itself. For example, better accounting for remote and vulnerable population. Population estimates from satellite imagery can be an operational alternative to out-of-date census data through the use of microcensuses. Spatial analysis can reveal gaps in service coverage and communities that are likely lacking access to vaccination sites. The estimation of resources for vaccination session can be based more on accurate accessibility information of specific areas, leading to a more efficient distribution of resources, and including identification of a new location of vaccination sites that can optimize coverage. Next slide, please. There's also a number of benefits that go beyond the direct support to COVID-19, but more broadly, strengthening the technical capacity and foundational geospatial assets that are required for GIS-based digital microplans can provide additional opportunities, for example, to support optimization and targeting of COVID-19 control and containment interventions by the use, for example, of better target population estimates, and the linkage with the location of health infrastructure can support distribution of testing treatments or personal protective equipment in a rational manner. It can also support other priority areas of innovation, for example, enhancing the geographic dimension of real-time planning and logistic monitoring and vaccination coverage monitoring by linking this data to the core geographic dimension information that is created at the health facilities and district level to support visualization and data use. And it also represents an opportunity to establish capacity and baseline data for digitization of API microplanning or support digitization of campaigns for other essential health services such as malaria, TB, or HIV, for example. Next slide, please. So in the next section, I would want to clarify a little bit how investments related to the use of geospatial data and technologies can be funded through the main COVID-19 related funding mechanisms that are currently available to countries, including the Gavi COVID-19 vaccine delivery support and the Global Fund COVID-19 response mechanisms. In the past several months, UNICEF and WHO have worked closely with both Gavi and the Global Fund to ensure that support for digital innovation and GIS-based microplan in particular is included as much as possible in these opportunities for support. Next slide, please. So the Gavi COVID-19 vaccine delivery support has been open since July, and as many of you probably know, with an early access window designed to make funding available in the short terms for all AMC 92 countries, with two separate application processes. A certain number of countries are required to submit directly to the to Gavi through the WHO Partners platform, while for other countries, the CDS support is available via UNICEF, and a separate submission template is provided directly to UNICEF country office. Gavi CDS an additional funding window will also be available starting from August 2021. And to be noted is, and relevant here, is that countries are encouraged to invest at least 50% of their CDS funding request to scale up innovations that support COVID-19 vaccine delivery, including operational cost and technical assistance. Next slide. So with regards to the eligibility of investments for geospatial innovation in the CDS, countries can use the CDS funding for all elements of their national deployment and vaccination plan, which are critical for successful scaling up. And there is a specific provision in the NDVP interim guidance that were released in June on the use of geospatial data and specifically digital microplans for equitable access and delivery of COVID-19 vaccines. We can also confirm that a country can request funding for innovative interventions related to GIS-based digital microplans already in the early access window, with the caveat that those fundings are to be utilized within 6 months. And additional funding can be requested for innovation in the additional funding window later as well. So there is a lot of opportunities in there to include GIS-based microplanning in this funding request, both for the early access window and for the additional funding window. Next slide, please. Gavi has also provided some illustrative examples of the type of innovative interventions that can be considered in the Gavi CDS funding request. And among these digital intervention, you can see in red highlighted specific indication of eligibility of GIS-based digital microplanning in the areas of planning and coordinations, as well as optimization of service points location to maximize coverage in areas of vaccination delivery strategies. I should note, though, that this is not meant to be a comprehensive list of eligible innovations, and therefore the eligibility to of investments in geospatial innovation is likely to have a wider relevance here to other NDVP programmatic areas, such, for example, identification of target populations and optimization of supply chain and human resources distribution based on the baseline data on population distribution and health facilities and health infrastructure location that is at the core of the GIS-based microplanning approach. Next slide, please. Now, moving on the Global Fund COVID-19 response mechanism, this has been opened since April or May, as many of you will know, with a focus on supporting countries to respond to COVID-19 and mitigate the impact on other programs of the 3 diseases. Although the C19RM opportunity has been out since May, with nearly a total of 120 countries now already submitting, we are mentioning it here because there is an additional window for full funding requests in September 2021. Countries also have the opportunity to reprogram savings funds from existing requested funding according to needs. After 31st of July, further resources could become available through top-ups funding. So there will be an additional opportunity to cover unfunded demand and reprogram investment associated to geospatial innovation if that fits into the parameters and criteria for the submission. Next slide, please. Next slide, please, Sunny. So key opportunities for inclusion of GIS-based microplanning in the C19RM include 3 main areas of support. Support the effective and efficient rollouts of national COVID-19 response plan by improving identification of target population and supporting the optimization of targeting and deployment of control and containment interventions, such as testing, treatments, oxygen, PPE, as well as obviously vaccine delivery, although that is not the main focus of the C19RM, but it is eligible. It can also, we also identified eligibility of the special investment for a mitigation of impacts of COVID-19 on the 3 diseases through the provision of foundational data sets for digitization of campaigns for malaria prevention, for example, or using the GIS infrastructure to target active case funding for TB, for example. And finally, there is a specific provision and eligibility of strengthening or establishing cross-cutting GIS capacity to support the strengthening of health and community-based systems, for example, through the strengthening of baseline data on health facilities and communities infrastructure that can support the community health-based systems. More information is available on a specific technical note on leveraging C19RM investments for geographic information systems, which is linked here, that was produced by the WHO-UNICEF GIS working group. So with that, I conclude this part of my presentation, and I will talk to you later after the country use cases, handing it over back to Sunny.
Right, thank you so much, Rocco, for that excellent presentation. And our colleagues, Dr. Rocco had actually given us a very good overview of digital and geospatial technologies for immunization microplanning, and also the funding opportunities, through Gavi CDS and C19RM. So thank you so much, and I know you have some questions. Please feel free to use the Q&A section, and after now we'll go back to the Q&A section to take your questions. Feel free, and we're excited to share the presentation slides after now. But yeah, we are going to move into the next section where we want to get the country experiences for this topic. And for today, we have the Lower People Democratic Republic as well as Myanmar country experiences to share with us. So going first is the Lower country experience, and of course that will be given by Dr. Hetet Argun. I'm sure I pronounced the name correctly. Please apologize if I didn't get it right. So Dr. Hetet is a health and nutrition specialist from the Lower UNICEF country office. He's actually leading the immunization and coaching at the country office. Previously, he has worked at the UNICEF Myanmar country office. That was over the past 5 years, and is currently supporting Lower country office on CONVAS, CDS, and CCE applications. In his work, he collaborates mainly with the Gavi's Initiative, USAID, WHO, JICA, Government of Japan, among many others, including the Ministry of Health. So please, Dr. Hetet, take the floor and let's hear from you.
Thanks, Sunny. Yes, good afternoon to all colleagues. I'm very glad to present on. Actually, this presentation is will be presented by the Dr. Konsai, manager of NIP from the Ministry of Health. But currently, he's on the mission and with the U.S. ambassador for the COVID vaccination. So I will present on behalf of him. Next. Yes, this is this presentation is a part of the CCE-UB delinking project, and we will show about how the CCE monitoring are being used of that monitoring for the project. So that's what we outline as an overview, and the CCE delivery with the use of GIS and the current tracking status of the how CCE delivery update and how the reporting and with the use of CCE dashboard. And updated is how we used in the smartphone application. Next. As we already noticed that the Gavi has been agreed for the pilot projects for the feasibility of the country-led service bundle under the CCE-UB. So the country and the ownership, the governments have to be take overall responsibility, and here's the development partner for the implementation. So to support for this to the government, the project management team has to be notice all the status of the project base and according to timeline, and also the delivery status of the country in country CCE. In our PDR, the country clear after on arrival, the custom clearance to be already done, and after that, the transportation agency will be handed over for the distribution list, and the agency it's ensure the right equipment to deliver to the right side. That is our NIP and our PDR would like to design it to have that area. To support for that objectives of the monitoring of the CCE delivery status, GIS-based tracking system is applied right now with the UNICEF LTA company to support for any change of or the deviation and how the status of the CCE delivery. Next. The CCE delivery is we are using the dashboard that is a dynamic map usually we see the GIS. map and the chart allowed to extend the monitor, explore the information about the equipment delivered and has been reported on the site. So it's already allowed to use the filter function to have facilitated the user interface for the depend on their requirement. It's already developed in Lao and English version. And at first it's designed to use the others like a GIS application, but depend on the user friendliness and the other things, and easy to use for the location, search and other things here. And it is right now used like Google GIS Data Studio. Next. And so the tracking how the with the CCE currently is like the CCE will be, we started to use with the CCE will be new delinking project equipment. So we can get the real-time information, provided the summary of the CCE categories and the location in each area. And monitoring with the use of filter is like according to the user preference I already mentioned previously. This option provided according to the level of the facility, examine provincial and district and health facility level. It depends on the who will be the provincial staff or how will be the national level staff. It depends on the use. They can monitor with the links. And it's already included the evidence of the delivery. So that the photo document are already included for the delivery, for the not only for the delivery, but also for the financial and other document. So it is easily accessible, and evidence already mentioned or included in that dashboard. And the map for the visualization is already included. User can adjust and to check for the location. And it is very useful to that for the report and other things. If someone is going for the monitoring or supervision by the third party, it is very easy to get the location and the location map. So it is very useful for that one. And detail list for the easy reference is also already included in the back. And following detail list is followed in the dashboard. Next. So this is like a CCE, inventory delivery. Right now, up to right now, is like we are it is two main parts. There is one thing is location, and another one it's like a type of CCE. And the location is right now total number of location where the facility already been delivered up to the level that is like summary. But and number of CCE delivery already being ongoing, and another one is like already arrived to the destination according to the type of CCE. And it is already followed by the evidence of the like a contact person, address photos, and also delivery place photo, and note for that delivery receipt already included in that one. Next. Yeah, and also it is followed by the detail list. Is like included the date of arrival, location, contact name, phone numbers, and photo evidence. This can also be generated into the Excel sheet so that the different provincial level and or district level depend on, they can easily find and generate their requirement to the like Excel database. Next. And it depends on reporting is not very much on the useful use for this one, but in case of something for the financial and the other things, if something would like to have know this for the detail for the like, so we have been developed a dedicated reporting dashboard that contains dynamic filter along the end user to search for the, but that is only the signal location, and it can generate a PDF format, which be the CCE delivery as requested location, and that photo on this one. It's already included in that photo document and evidence and everything in one PDF file. So it is useful for the other reportings and the other procedure. If the user want to have print multiple location on report, but it is like he or she has to be reiterate the location research process. Next. So right now it's like we are providing quick access on the information via the smartphone. Is mostly is previously we are using on the web-based information, but right now it's like for the usefulness and the requirement on the feedback from the field level staff, we are already developed for the quick access for the information for the smartphone. So report is similar to the reporting dashboard. On the we are developing the smartphone for the quick access. It is a mobile version. Is create easy access to information via the user mobile. They can access an easy location as shown in the previous dashboard. But the function is like they can trigger how they can trigger the Google Map application on directly, for example, which location and how many. This is easily already mapped out with the use of this function. So advantage is like this smartphone is like easy reference from the field, navigation from hospital or office or their location to the designated CCE area. And it is already included easily for the contact person name and number. And the reference document already included on this smartphone application. Next. Next. Yeah, so with the use of GIS in the cold chain inventory, it is like I already shared, it is like a quick tracking for the cold chain inventory system. And it is very useful for the distribution list of the E3 reference and reference checking. And with the inventory document is really useful. And right now we are also already being like with this CCUB delinking, not only for we are planning to develop with the existing cold chain inventory into like this one also, and contact list, detail list for the health facility already being included, and update summary in visual map, and easy reference as a last after this GIS mapping or the CCUB project. This system is still available and useful for the CCE inventory. Next. So we forward this like we are still ongoing. This is like still developing and we are learning. So ongoing, we will have according to feedback and suggestion from the field how they will be more utilized and usefulness for them. And we are starting from the end of this year, and next year we are planning to develop update on all in-country CCE like this one. And we are planning to have a future on the capacity transfer for the MOH and NIB for after this project and the inventory to them. Thank you. Thanks.
Thank you so much, Dr. Hartak, for that excellent presentation and for giving us insights on what's going on and the great project you are working on. We are really excited to see how this evolves over time, and we are excited to share that with participants as well in the next couple of series of our webinar. Thank you so much. So the next we are going to call upon the country office, Dr. Satish Mena. So Dr. Satish is actually the immunization manager at UNICEF Myanmar country office. Dr. Satish is presently working as the immunization manager with UNICEF Myanmar country office. He's a medical doctor with master's degree in pediatrics. His role is to influence policy and strategies for strengthening routine immunization, especially in the context of health system strengthening, and to support the use of innovation to reach marginalized populations. These actually include children in urban slums, migrants, and those affected in conflicts affected populations. He is also the focal lead that supports COVID-19 vaccine rollout at the country. And prior to this, Dr. Satish actually worked with the UNICEF, with the WHO country office in India, and he has, well published, over time in reputable scientific journal across the world. Dr. Satish, please, the floor is yours.
Thank you very much, Sunny. So I'll be taking about 10 minutes to discuss about the geographic information system for immunization microplanning. So GIS microplanning actually which we have used in the last 2 years, and this I am presenting on behalf of my team, which is a very strong team of my colleagues who are working in Myanmar. And we also got the guidance and support from ROCO, and also we should thank ROCO for this. Throughout this process of GIS microplanning, we also got the help from Mr. Steve Ebner, who also helped in developing the microplanning process. So next slide, please. Yeah, so the outline of my presentation includes the immunization program and the current challenges. and the use of the GIS tool for microplanning and its potential use within and also beyond the immunization program, the challenges and the way forward. Next, please. Yeah, so immunization program in Myanmar. So I'm just talking about before the military coup, and you know the situation has changed recently because of the military coup from 1st February, and there has been a limited engagement with the de facto administration. So my presentation is mainly talking about the situation which is prior to the military coup in February. So the immunization coverage has been remained stagnant in Myanmar for about 90%, and there are actually children who have been missed. And you can see in the map in the center, there are populations and the people who are get missed, and the coverage remains low, less than maybe 50 to 60% in many of the border areas with Thailand, with China, and India. And also there are large number of migrant population, and you can see on the right side there is a huge migration in Yangon and around Yangon, and there are large number of people who are staying in the urban slums or in the non-registered population. They have actually settled in, and they are many times they got missed during the vaccination program. So this has also been reported during the EPI review and the annual evaluation meetings in Myanmar. Next, please. Yeah, so when we know that the children are getting missed, so one of the strategy which WHO and UNICEF has recommended as a reaching every community strategy, REC strategy, and the RED strategy initially, which focuses on improving the coverage through preparing a microplan based on the population and also based on the community which are living in that geographic area. And one of the important tools for making a microplan or the catchment population is the map. And you can see the first map on the below, which is shown in the reaching every community guideline. So there's a map which shows about the health facility, the population, the major roads and connections. And if you see on the right side, on the second map, which normally a health worker in Myanmar, we just given an example, how the maps are being prepared based on the standard guidelines which are issued by the RED and the REC strategy. But there are also issues with these maps because when we talk about the population which needs to be covered and the health facility which are providing services, we need to know about the people who are living, whether it's a formal population, whether it's a settlements, whether it's a people who have migrated. And this situation keeps changing because of the large scale of migration, especially to the urban and the peri-urban areas. So for that, actually, we started using this GIS system to improve microplanning and monitoring. And in that, we go to the next slide, please. So in that, actually, we have three things: API community, health facility, and also the vaccination post. So these are the three important things. And when we say EPI community includes all the people who are living anywhere, whether in a formal colony or whether it's a migrant or whether it's a scattered people who are living in a village site. So to deploy a GIS-based microplanning is a process which includes starting with the development of the SOP for data collection and the application, and also to map EPI community. And EPI community, as I mentioned, this includes all the population which are living, whether it's a scattered population or whether it's a defined population in a village or a urban part. We also need to have the master list of the health facilities and also the vaccination post, outreach, and the fixed sites. Then based on this information, we have to also develop the EPI community boundaries. That means the boundaries which are, so for each catchment area, we have to define the catchment area. And for this, actually, in Myanmar, we use the Mapathon, or so we use the volunteers who helped in developing the boundaries and also identifying the population within this area by not only by the GIS and GPS coordinate, but also the other intelligence they had from the local communities. So we did the API boundary development through a Mapathon exercise, and also we produced the GIS-based micro-planning maps. And we produced two types of map. So one is the static map, which can be printed in a PDF or can be circulated through the emails and the WhatsApp media. but we also developed a web-based application, web-based system where we can use it through the computer system. And then based on these maps, both static map and also the web-based maps, we did the training of the health workers to use these maps for preparing their or updating their microplans. Because microplans in Myanmar, they are updated once a year. And this time in 2020 and 2019, we use this microplanning using the GIS mapping. 2019 and beginning of 2020, before the COVID actually sets in. And this was also used for identifying many of the missed pockets. Next, please. And just to say that this map process in Myanmar, actually we use the public health system. So we use the healthcare workers working in the health department. So we use the midwives, the supervisors to collect the GPS coordinates, to prepare the maps. So it took almost 6 to 9 months for developing maps and also developing the microplans for one state, because we used a phased by phased approach. So that's the time it took, almost 9 months for developing Yangon microplan, and then we expanded to another states. So coming to the web-based maps, so they provide a comprehensive picture of microplans at all the levels, going down from township and below to the regional and the state level, and also at the national level, and without going through the hundreds of paper-based maps. And this can be done either through a computer web-based system or through a development of a tablet or a mobile application for use in tablets. And you can see one of the maps there, actually the mobile-based map which we are using this thing, and also the Gavi CEO, one of the midwife, is also showing the GIS mapping to Seth Berkeley when he visited to Myanmar in Yangon. Next, please. So one of the advantage of this mapping, GIS mapping was, although it was started for vaccination program to provide additional information to the midwives to plan their vaccination services, and also to provide the geographic boundary of their vaccination catchment area. But we also saw that this map can also be used for multiple other information systems, like for LMIS, for malaria control program, for disease surveillance program, for health management information system. And recently, actually in Yangon, though the maps were developed for a peri-urban area, but recently during the social health security scheme, which was launched in Langtara township of Yangon, these maps were also used for the cash incentive and the social health insurance scheme service, which was launched in recently in 2020 and 2021. So these maps will also be being used to find out the catchment population and also to map them according to their geographic locations. Next, please. And one of the additional advantages that some of the areas which were missed during the traditional microplanning, we also got identified. You can see in the first image, there was a small population which was not being covered through the traditional vaccination program. But during the GIS-based microplanning, we could identify this additional area and then later on got included. And similarly, in the second image, you can see also some of the areas, because actually Yangon or the urban area, they are ever expanding. And you can see every year there are more populations coming from the rural area and from other parts, and they settle into the peri-urban areas, and especially and creating new areas. So this new areas were not part of the traditional microplan, and they were getting missed. So this were also included when this mapping was done for the GIS-based microplanning. Next, please. So one of the challenge actually when we were developing this GIS microplan is the gaps in the HR availability, because we use the public health system and we use the health department staff, the supervisors and the midwife for data collection, boundary development, and also the training. So, and they have also many other programs which they are running, from vaccination, from antenatal care, RMNCH. So there's a limited availability of these staff to actually provide time for for this GIS-based microplanning, which is also intensive in the beginning. And also, as I mentioned, we took almost 9 months for the development of this GIS-based microplanning because of the limited staff, especially. We had one international consultant and one national consultant to support the process, but the rest of the work was done mainly by the public health staffs from the health department. There are also challenges, especially in the some of the areas which are like self-administered area or the armed conflict area. They are very sensitive to the sharing of this information, and which can also hinder the data collection process and use of maps. So we also actually are aware about that these maps, although we have planned to do national rollout, but there are some areas, especially the border area with China, Thailand, where we have ethnic health organization and ethnic armed organizations, and their data collection is not going to be an easy, and there will be a lot of challenges to collect this data. And also the lack of an up-to-date availability of the GIS maps, especially for the rural and the remote areas. So we have to actually rely on the data or the maps from the Google and other sources. Next, please. So the way forward, so what we have seen that the immediate benefit is that we got the community definition well defined. So, and this can be used not only for EPI, but also for all the programs. The health facility distribution also got visualized when we were doing this mapping. We also identify other migrant populations, which were maybe not formally known to the health department, but they were people who migrated recently and they were not included into the normal planning process. So this also helped in preparing the boundaries of the EPI communities, and also helped in reviewing the session planning and also identifying the possible locations if we have to relocate some of the microplans or some of the health facility for vaccination services. This helped us in actually doing the replanning. The long-term benefits are the identification of the GIS products and the tools actually helped us in preparing the microplanning and preparing SOP for the further scale up, and for the also integration with other programs like malaria program, RMNCH program. And also this built up the capacity of the counterparts, the ministry counterparts at the different levels, state, central, and the regional level, because they are the ones who actually implemented this program. And we only provided some technical assistance in this process. Next, please. Okay, this is all actually from me, and for any additional query, you can maybe ask me. Thank you very much. And thank you very much, team, for giving this opportunity to present these slides.
Thank you so much, Dr. Gupta. That was an excellent presentation, and participants, you could follow up, to understand or to see how some of these work that Dr. Gupta is leading evolves. And in the next couple of webinars, we are going to update you all on the project which he has actually presented. But a couple of announcements before we call upon the last presenter. So we had expected this webinar to last for 90 minutes and not 60 minutes. So we have the next 30 minutes to wrap up things. And for those who can't stay for the next 30 minutes, you can actually drop off, no problem. We share the recordings and the presentation of the slide with everyone in the coming days. We assure you that, but we have just one presenter and we'll be done for the day. And also remember, as we said initially, to use the Q&A feature, which has actually been enabled to type your questions, and don't actually type that in the chat box to ease the work we are doing. And also after now, we'll be going to the Q&A section where we itemize or prioritize some of the questions. I will call upon the focal person to actually answer some of those target questions. So next we'll be calling on Dr. Rocco once again back to the stage to give us an overview of the implementation of the microplanning, talking about the procedures, the steps, the support available through the WHO-UNICEF GIS working group. And I think what is going to talk on is, we'll address some of the questions that people have actually started asking. So, Dr. Rocco, please, the floor is yours.
Thank you, Sunny, and thank you to Dr. Satish and Dr. Ted for the good presentations. I don't want to take too much time so that we can open the floor for Q&A, but I wanted to give a brief perspective on some the steps involved for initiating a successful implementation of this kind of innovation approach. Next slide, please. I'll just start by saying that the sustainable implementation of this kind of technologies relies on the establishment of a suitable geo-enabling environment or enabling environment around the use of geospatial data and technologies, as we call it. This kind of the element of this geo-enabling environment are akin to those of national e-health strategies and include elements of not only or institutional policy, strategy, governance, and resources related to the integration of geography with the health information systems. And this is institutional framework is required to then ensure that the resources are available to ensure the availability of technical capacities and core geospatial data to then essentially support the foundational data for application of GIS to the health sector and microplanning, which are the georeference list of health facilities, the population settlements, and boundaries of reporting and catchment areas, which is kind of at the core of this whole process. The deployment of GIS-based microplans for COVID-19 response can, to a certain extent, in the short term, hinge on input of technical capacities, geospatial technologies, and core data to countries. But it should be kept in mind that the sustainable establishment then of GIS-based digital microplans for example, for API, for primary healthcare, will require a longer term institutional vision according to this type of framework. Next slide, please. So with that in mind, where should countries start if they intend to implement this approach? So the approach suggested, which is kind of explained in a number of technical resources as being formalized in a number of technical resources which is linked here, is really that of starting from the identification of the gaps and the priority bottlenecks for COVID-19 response, and then use some of these resources to identify how to what extent GIS-based solutions can address this bottleneck, and with respect to, for example, other type of digital innovations, to ensure that it is the right solution that is selected. And once this has been determined, we highly recommend a structure assessment of the current enabling environment as described earlier, because this can identify is the first stop really of support to countries, because it can identify gaps in core data sets, in availability of technical capacity and resources required for a successful implementation. And it can also point out to existing assets in the country in terms of capacity for GIS and data that can be leveraged to speed up to facilitate the implementation. So depending on the outcome of this assessment, then we find that typically the first need we support countries responding to is the prioritize planning for completion of the core data sets. That is the completing the georeferentiation of the health facilities master list, or vaccination sites, or cold chain infrastructure, for example, in the case of the application shown for Laos. And assess the availability or plan for improvement or filling gaps in population estimates, for example, using some of these technologies. Once these priorities are covered on baseline data, and some level of technical capacity is established or outsourced for maintenance and analysis of this kind of information, then we can move into a detailed planning for the actual deployment of the solution using this baseline data at district and health facility levels as core to the microplanning approach. So there's a number of technical, and I should say in parallel, then we always recommend establishing a plan for strengthening the remaining element of the enabling environment. For example, establishing some or strengthening existing governance structure around management of geospatial assets in the country, whether it's within the MOH or within the MOH and other government agencies that might already have mandate for this kind of data. So there's a number of resources there that I pointed to that can support this process, but the WHO-UNICEF GIS working group can also support countries in utilizing these resources to do this assessment and plan for implementation. And I'll detail that in the next slides. Next slides, please. So the WHO-UNICEF GIS working group is a spin-off or subgroup of the COVAX innovation group that was described earlier. And it's really a global level coordination effort to support countries in a number of ways in the phase leading up to the implementation process. To this end, it puts together a number of donors and development partners, and it also has linked with over 30 GIS data or services providers that are somehow linked through the GIS working group in a kind of to kind of like have a broader look at the overall technical capacity that is available out there, and to link that to countries' needs. Next slide, please. The main type of support the GIS working group can provide, as I said, supports leading up to implementation, mainly in a number of areas, including informing on the fundraising efforts and with a number of information products that we have developed to support countries in the integration of geospatial investment into these funding mechanisms. We have some tools to support countries in identify their needs and do an initial quick assessment of the enabling environment that I was mentioning before, to help identify what then are the priority activities that should be implemented. And we also act as a link in between the GIS solution service and data providers and the country requests for assistance. We have, to that end, we have developed a number of information products and can support countries in through bilateral consultation on using these products for country-specific assessment of their context and support some of the planning and costing phase. We have some country budgeting tool that can support costing some of the activities related to the implementation of the approach. You can find more information on and contact details on the working group website that is posted here. Next slide, please. And I will leave you with some specific contact details related to both technical assistance for digital solutions for COVID-19 response and also specific contact details for the GIS working group. And with that, I think I will close it, my presentation. And I know there's a number of questions in the Q&A chat, so I will ask Sunny to facilitate this Q&A session. Thank you.
Right, thank you so much, Dr. Rocco, and I appreciate if you remain on stage, please. And also I want to call upon the other presenters. Dr. Gupta, I think there's a question for you. Karen, and yeah, I think pretty much is between you, Rocco, and Dr. Gupta. Then of course, Karen, you could also weigh in. All the presenters, please, can come up. So let's take the first question to Dr. Rocco. But pretty much most of the questions has actually been answered. So I actually itemized, about 4 or 5 questions, given the fact that we have 15 minutes to the end of this section. But we are glad to continue offline to answer your question and get back to you afterwards. So the first question to you, Dr. Rocco, is there any example where GIS microplanning and vaccination coverage have been integrated and analyzed together? Will vaccine coverage recording portal be linked to the GIS microplanning portal, or are both integrated?
Yes, thank you for the questions. There has been some example in the Middle Eastern region of a linkage between GIS microplan and vaccination coverage dashboards, where vaccination the vaccination coverage was tracked specifically and visualized specifically on the geographical unit of the lowest level geographical units of wards and health facility catchment areas. The other thing to note is that the DHIS2 itself, for example, has expanded the geospatial modules and the ability to handle geographic information for reporting, and there are already examples of reporting of coverage indicator in the through GIS visualization through the DHIS2 modules as well, and that capacity is expected to kind of be expanded on the DHIS2, and the ability to bring more information on the population denominators as well as the vaccination coverage information in the DHIS2 information system as well.
Right, thank you so much, Dr. Loco, for that comprehensive answer. But I would appreciate it if you any question, you keep it to 1 minute while answering it, so that we keep the time. So Dr. Gupta, the next question is for you. Do you implement the GIS microplanning to include also other MCH programs, talking about antenatal care, postnatal care, nutrition related activities? If so, can you share briefly some of the experiences?
Yes, thank you, Sunny, for this question. So yeah, so this is what actually we thought in the beginning when we prepared the microplanning for immunization. So in 2019, late part of 18 and 19, we prepared the microplanning for routine immunization in Yangon and in other areas, expanded to two more states. And the purpose was to use it initially for immunization, but gradually expand to other programs, especially HIV, TB, malaria programs, and also RMNCH programs. However, because of this situation in Myanmar, the program got interrupted, and now actually we are not able to expand it because of the de facto administration and our minimal agreement with the military government. And also we know the sensitivity of this data if we collect it now to the military administration. Having said this, we also recently, actually in 2021, the Social Health Security Scheme, which was launched in Yangon region in urban area, especially the peri-urban slum area. So that actually used the data which was collected through GIS microplanning for immunization for launching the social health scheme in that area. So that's the only experience we have beyond immunization right now, where we used GIS for beyond immunization. but we had the plans to expand it to other interventions as well. Thank you very much.
Thank you so much, Dr. Gupta. And yeah, back to you again, Dr. Roko. Please, would you advise country offices on specific activities and budgets required for the implementation of GIS microplanning?
This is kind of what I was trying to answer with my last few slides. It is very country dependent and linked to the country context. So our suggestion is there's a number of resources or guidances on specific activities and planning guidances related to not only GIS-based microplanning, but GIS for immunization in general, around about 8 use cases that is included in the 2 links that I have posted on the slides. Through the GIS working group, we can help countries interpret and apply those guidance to really fine tune some of the activities. So I invite whoever made the questions and interested countries to reach out to the GIS working group through many of the contact details that we have posted for specific support on that.
All right, thank you so much, Dr. Roko. And back to you, Dr. Gupta. How does unvaccinated children find out through GIS map? As I understand, GIS map can show settlements only, not providing data of target children. And for that, someone needs to visit those settlements.
Yes, thank you, Sunny, and this is right. So we found out the populations or the EPI communities. That means all the population which are living in the catchment area or beyond the catchment area. So we found out through the GIS mapping, but their immunization status is only through the visits. So, but actually one of the issue especially with the peri-urban area and difficult to reach area is that there are areas which are being missed out. So there are areas which are not in the township planning, and there are areas which are if you add all the microplans of all the midwives. You will find that some areas which are not in the any one of the midwives catchment area, and through this GIS mapping we found out that if we add all the microplans of all the midwives of a particular state or a township, we could find out some missed area, and there are people who are living through the GIS mapping. We know the population which are living there. So by adding that area into some of the microplans, we could find out their immunization status by assigning that area to a particular midwife or to a particular catchment area of a particular vaccination session. Yeah, that's true. Thank you.
Thank you so much. Thank you so much, Gupta. And yeah, back to you, Dr. Roko. Is digital micro-planning applicable to all types of micro-plan conduct, like the walkthrough, write-through, desk reviews? What do you think? And after now, we'll take one more question and we'll wrap it up. We are actually running out of time. Roko, please.
I have to say, I don't fully understand the question in terms of walkthrough, right-through. I think it refers to the various vaccination sites. I mean, what I would say is that the aim is to provide based on the local context, to provide the geospatial information on the location of settlements with respect to existing vaccination sites, and then support, for example, the identification of the accessibility of those sites based on the distances, and in that process, one can consider the type of transportation modality that population will use, and there's ways to kind of integrate that into the GIS analysis to differentiate a different type of population movement. I hope that kind of at least partially answered the questions, and I'm sorry if I didn't fully understand it.
Right, thank you so much, Dr. Roko, for that answer. And I'm going to give the floor to one of the participants to ask the last question. and that will actually, wrap up things. Please, Ibrahim Musa, can you unmute yourself and ask your question? The one you asked about, how does the system differ between hard copies and ODK? Because the question, if you type it clearly, is not, very well understood. Ibrahim Musa.
Yeah, good morning, good afternoon. I'm calling from, I'm teleworking from Nigeria. What I was trying to ask, the past, previous micro planning, you get to just the downstairs. When you get to a community, you have your own hard copies and you have the ODK software being installed on your own system. After generating those information, you impute those information based on what you want to use that information for. And when you input those informations into the ODK, you send it to the server, then it will be downloaded and do your own simple analysis. Simple elaborate, like before it was attached to like kilometers, but now based on this presentation from Dr. Rocco, is like it was like saying is attached to time. If it is attached to time, then how can you estimate, like places that you can you not use like motorcycle, bike, it is how can you estimate that time to get those that are coming as a fix, those for outreaches and the mobile. Thanks.
Thank you, Dr. Ibrahim. So if I understand the question properly, the objectives is really once we build a capacity, for example, to collect and assess the geographic layout of health catchment areas, that allows us then to apply the GIS support in depending on the context that is desired. It can be just printing maps and using those maps for people in the field, like done in the North Nigeria, for example, to better collect ODK data, or if the capacity allows it, integrate that into a GIS system that can then support, for example, mapping of converting distances to travel time. It can be done through some assumptions on the local modes of transport. But that will always, is not a universal kind of set approach. The core is to create the geospatial information and collect the geospatial information so that everything is georeferenced, and that then gives us the flexibility to either consider distances or travel times according to the local needs and mechanisms by which decisions are made. I hope that answers your question to some extent.
Yeah.
Right, thank you so much, Dr. Ruko. And someone has asked a question asking how to reach out to GIS working group to start, the process. If there are any platforms, mail, or for official communication requests for funding. Technical guidance supports, will be helpful, especially should official requests go through the MOH or country office or through the regional office. So I think that's part of the last slide. So maybe Benny can move to the last slide while Rocco attends to that, and we'll wrap up things using that.
So it's a multi-part question. So the GIS working group can be reached through this rapid country assessment survey, or through one of the emails, better through the rapid country assessment surveys that will ask to provide some information. So that's kind of the official request. DICE is also able to support some of this process. So the request can also be channeled through some of the DICE regional representatives. It's true, not for funding. At this stage, we are the GIS working group is only providing information on the eligibility of fundings, but when it comes to specific requests on processes and for funding, I would ask people to directly relate to their Gavi senior country manager or the Global Fund country teams. So, but the GIS working group can advise on the eligibility of some of the activities specifically related to GIS. And regarding the request through MOH or country office, again, that depends on the specific mechanisms, and I would really refer the person requesting to either the Gavi senior country managers or the Global Fund country team if they are in the countries that are applying directly to Gavi for the CDS. Otherwise, the request can come through UNICEF, and I think that kind of answered most of the questions that are there.
Yes, please, Dr. Loko, that was an excellent, wrap up of the question that was asked. And participants, with that, we come to the end of this section, and we assure you that we are going to share, the presentations alongside some of the questions and answers that we have asked, even those that we could not attend to today because of time. We are at the top of hour now, and we hope that moving forward, we will continue, the series of this webinar, and also to assure you that we're going to send you some of the input and reflection that we've had today. And also, we implore you to join us in our next, webinar coming up, which shortly we will communicate to you on. Thank you so much, and I'm going to call on Dr. Devi to officially close us out. Dr. Devi, please.
Thank you so much, Sunny. And again, thanks to everyone for joining this really highly informative webinar, which I hope was very useful for all of you in continuing to roll out the COVID vaccine to reach the unreached, as well as in reaching the children and other adults that may likely come in later on for immunization, as well as other health services. And thanks to our colleagues from Laos and Myanmar for sharing their experiences as well. And other presenters, Karen, Rocco, as well. So thanks very much. And please do not hesitate to reach out as Rocco has presented, because these are going to be very useful. Thank you very much.